Good afternoon. We will now be starting with our virtual e-poster presentation. Our first moderator is Dr. Suresh Kumar. He's the director of the WHO Collaborating Center for Community Participation in Palliative Care and Long-Term Care. He works at the Institute of Palliative Medicine and Medical College in Calicut, Kerala, India. Thank you for being here, sir. I kindly request you to come up to the moderator's desk. Our next moderator and judge is Dr. Ramani Atkuri. She's a senior public health physician and researcher. Thank you for joining us, ma'am. Presentation, which is by Dr. Niharika Manchikanty. She's presenting on sexual orientation, universal health coverage.
And its impact on universal health coverage. Coming to gender discrimination, it is actually very real and prevalent within the healthcare system, whether it is for the patient or for the provider. Exemplifying this trend, often unconscious and subconscious biases that affect healthcare receivers to a very high degree, there has been significant emphasis on different health disparities. For example, it can be race, ethnicity, or socio-economic or gender disparities, but a very little emphasis is laid on sexual orientation disparities. The lesbian, gay, bisexual, transgender community or the LGBT community is becoming visible nowadays in the society due to recent civil rights that has been gained. It helps LGBT community to become more visible, reduce stigma, and facilitate access to health insurance and healthcare. Therefore, the care for LGBT persons received may not reflect an awareness on LGBT specific concerns. So the social determinants of health are particularly influential drivers of LGBT health disparities. Higher rates of unemployment or underemployment, limited access to appropriate healthcare, and social discrimination that affect the behaviors of LGBT people, which help them engage, and it may need different strategies to improve the health of this population, especially. The LGBT population almost experience all kinds of similar diseases and conditions that are prevalent in the normal and the broader society. For example, cardiovascular disease and other infections and other chronic inflammatory diseases that may also affect this LGBT population disproportionately. So LGBT health disparities occur throughout their lifetime, and LGBT youth are more likely to be bullied, commit suicide, engage in sexual risk behaviors, and run away or to be forced to leave home. And the social challenges that accompany them, which result in higher rates of homelessness, including mental health issues, violence, HIV, other STDs, poverty, substance abuse, and food insecurity. LGBT elders are most likely to live alone and less likely to have children that limit their access to sources for social support and for assistance with the activities of daily living with chronic or acute medical conditions. The data on the social discrimination, inadequate legal protections, mental health disparities are mixed, and violence, including bias crimes, remain a major public health issue for LGBT persons, although the level and types of violence differ among these subpopulations. In a rare national study, an estimated 39% of gay men, 15% of lesbians, and 20% of bisexual men, and 15% of bisexual women reported having ever experienced physical violence, property crime, attempted crime due to anti-LGBT bias. LGBT youth and transgender women are particularly susceptible to physical assault, sexual assault, and murders. Though sexual forms of victimization are poorly documented, according to the available data, their lifetime prevalence is very high among the lesbian and bisexual women, which is actually 43.4% than among the gay and bisexual women. Estimates from the National Intimate Partner and Sexual Violence Survey documented in 2010 61% of bisexual women compared with the 44% of lesbians and 35% of bisexual women. And they experience intimate partner violence related physical violence, stalking, rape, and 37% of bisexual men as compared with 29% of heterosexuals and 26% by gay men experience these outcomes. Coming to these subpopulations among the LGBT community, lesbians have higher rates of alcohol, tobacco, and other drug abuse, which is associated with cardiovascular disease and obesity. On average, lesbians have actually greater mass by body mass index when compared to heterosexual women, as they become less responsive to social pressures, and they lose less weight and they have less loss of appetite, etc. Lesbians also have an elevated risk for some types of cancers because of their combination of lifestyle factors and other factors. They also experience disparities in breast, colon, and lung cancers due to obesity, tobacco, and alcohol use. They also have elevated risk for gynecological cancers such as ovarian and breast cancers because of they not ever being because of them not being pregnant or delayed or inadequate gynecological screenings. These can be prevented by timely and appropriate health screenings for preventable diseases that prevent many of these health issues, mainly among lesbians. Among the gay men, HIV and AIDS remain major threats to the health. The higher prevalence of HIV in this population means that any member of this population who engages in higher risk HIV behaviors have an elevated risk of acquiring it. Based on the data in 2008, among the gay and bisexual women screened for HIV infection, the Control for Disaster and Communicable Diseases estimates that HIV prevalence among the gay and bisexual men is 19%. These can be prevented by timely and appropriate screening at least once a year, choose less risky sexual behaviors, and limit your sexual number of sexual partners. Use condoms correctly every time you have sex and consider for pre-exposure and post-exposure prophylaxis. Behavioral and adaptive counseling is very important, which actually plays a major role. And coming to the image given here, it is actually a National Gay Men's HIV Awareness Day, which is actually held on September 27th. On this day, across the nation and across certain parts of world, there will be awareness programs and certain activities that create awareness in about HIV and AIDS, especially in gay men. Bisexual persons have actually a disproportionate burden of HIV and AIDS, which also have other health disparities and which also account for other health disparities. And one such main issue is the intimate partner violence. Coming to the transgendered persons, especially transgendered women, they also experience particular health disparities which are actually driven by social determinants of health. Poverty leads transgender women to engage in sex work, which put them at risk of violence, substance abuse, HIV, and other sexually transmitted diseases. Other health disparities affecting this subpopulation include depression, self-harm, suicide, and complications due to use of cross-sex hormones, some of them which can be obtained illegally or some may be of poor quality. These can be prevented by counseling and implementation of family and parenting-based programs, healthy relationship skills, creating protective environments in and around them, especially in schools, colleges, or everywhere they most commonly go. Support survivors or victims to increase safety and lessen harm. Some of these disparities that LGBT people experience reflect the ways that LGBT status may intersect with other minority statuses also. Among the transgender women, racial and ethnic minorities report disproportionately higher levels of incarceration than their non-minority peers, and the qualitative findings suggest that these concerns about racism may be at least little valuable as those of sexual orientation and gender identity. Perhaps the greatest challenges faced by these transgendered persons and their providers involve the need of multiple simple or complicated surgeries and long-term administration of sex hormones. Both require complete dependence on healthcare systems, some insurance that reimburse their expenses completely or partially. The need for these services is compounded by the particularly low levels of income and health insurance in this population. So this omission is holding back more efficient healthcare as gender-based prevention measures or therapies are more probably effective than usual one-size-fits-all. Approach justifying my idea of equity is giving everyone a shoe that fits. Coming to the image on the left side of my poster is the transgender one-stop service that is present in my college, Andhra Medical College, affiliated to King George Hospital, Visakhapatnam. Every time we see different types of communities of LGBT community subpopulation approach here for their health concerns. It's actually a very good initiative that has been taken. other reforms must be taken place, and most probably it lags behind about the economic things, as we already discussed about the multiple simple and complicated surgeries and the administration of sex hormones, which usually requires reimbursement of health insurance or health care. So this actually justifies my idea of health equity, which is giving everyone a shoe that fits them inside. Thank you.
Okay, I can see that there is a clinic or there's a treatment center at your institution, but all the data that you quoted nothing to do with your center. No, the data is not from your center. Data you have quoted some data from CDC, something from a national survey. Why was that?
Actually, we have people coming from LGBT community in a very single digit or in a double digit, sir. So it is not actually, that is what is my point, sir. People are very shy and they do not come out to approach us for their concerns. So there is no sufficient data in our place also. So that is my point. Being such a big platform, I choose this because we have to include LGBT people themselves because they know better, so that it will motivate other people of their community to come forward and address us better.
Questions. One is, I remember in many places, every hospital has what is called a VDR, a STD clinic. Nobody used to go there because it meant that if you entered that door, that you had a sexually transmitted infection. So putting up this thing saying transgender care clinic, that itself might be putting off people, those who are non-binary and not obviously, not physically obvious. The second question, my second question was, how much has the college done in terms of sensitizing the people who handle or to work with non-binary genders and their special needs? Has any work been done in that in terms of the curriculum or in terms of educating staff?
No, ma'am. Actually, according to the rights that have been given to the transgender population, these are the main small minor things that are left behind. We actually must include them in every workshop or social gatherings or everywhere we attend that are based on focusing on development of society. So it will not only boost their confidence, but will also make them comfortable. And we also must include this kind of curriculum in the schools and colleges that will make people aware that they just differ from us according to their biological system, but they are actually similar to us. We also must include these people so that they can discuss directly with us about the issues that are occurring.
I was talking more about the staff in the hospital and the medical college being very biased against transgenders, and whether anything has been done to assess the bias and to address it.
No, ma'am. Not so far. It is actually written on the papers, but it is practically not being implemented. Very less percent.
Thank you.
Questions from the audience? If there are no questions, we'll thank you, Dr. Niharika. We'll move on to the next presenter, Dr. Bhadaru Naik. He's presenting on Violence, India's Masked Health Inequality Story.
Violence, India Masked Health Inequality Story. Background. In the past 3 decades, violence has become to be regarded not just as criminal justice issue, but also a public health problem. Different form of the interpersonal violence have always been a part of human behavior and being evolving every now and then. Extraordinarily, violence are not only limited to the homicidal, sexual, child abuse and neglect, but also include firearm violence, intimate partner violence, bullying, elder abuse, many others. In addition to the potential for death, disability, and other injuries, people who survive violent crime endure physical pain and suffering and may also experience a mental distress and reduced quality of life. Any person can be affected by crime and violence either by experiencing it directly or indirectly, such as witnessing violence, property crime in their community, hearing about crime and violence from other residents, while certain group of people are more likely to be exposed. The percentage of violence is showing in this diagram. The incidence and prevalence, crime rate vary greatly from country to country and are influenced by many factors. Venezuela has the highest crime rate in the world. It's the 83.76 measured per 1 lakh citizens. Iceland ranks as the world's safest country with the lowest crime rate, achieving 1.107 rating on the Global Peace Index. The index accounts for the conflict, political instability, internal disturbance, and potential terrorist attack. India crime rate and statistic for 2021 was 2.94, a 0.86% increase from the 2020. India crime rate and statistic for 2020 was 2.91, a 0.53 decline from the 2019. India crime rate and statistic for 2019 was 2.93, a 2.24 decline from the 2018. A crime rate and statistic for India 2018 was 2.99, a 1.16 decline from 2017. The diagram shows the decremental percentage of crime rate in India, but from 20 to 21 shows the flat line. There is also a strong correlation between age and crime, with the most crime, especially violent crime, being committed those ages 20 to 30 years old. Women are more likely than men to sustain injury from the assault and are the increased risk of arthritis, asthma, heart disease, gynecological problem, and risk factor for HIV or sexual transmitted infection. Then those who do not experience violence for men, community violence is likely to be affected their health and are much more likely to commit suicide than women, regardless of age, race, and ethnicity. The scientific understanding and biological effect of violence have become increasingly better understood and include effect on the brain, neuroendocrine system, and immune response, development of neuroscience, and the study of the effect of the environment on multiple aspects of human biology focused have increased risk of heart disease, cancer, substance abuse, depression, impaired social relationship, aggression, and risk-taking behavior. And the mechanism include changing in the structure of the brain, white and gray matter, and it value and functional connectivity, altered neurotransmitter metabolism, change in the neuroendocrine stress response, chronic inflammation, impaired glucose metabolism, and change in the microbiome in response to stress. While these changes may have most prominent infancy and early childhood, exposure to violence in later life can have similar biological effect. The biological effect of this exposure are modified by genetics. The characteristic of this exposure, social and community context, and degree to which exposure are chronic and combined with other adverse exposure, such as exposure to poverty, child abuse, associated with increased risk throughout the life, course of depression, suicide attempt, and ideation, substance and drug abuse, obesity, sexually transmitted infection, risky sexual behavior are both on potentially some chronic disease such as arthritis, ulcer, and migraine. Additionally, the odds of delinquent and violent behavior are 1.7 times higher for people who experienced chronic childhood sexual abuse, 1.28 times more likely to be report carrying weapons than who did not. Among the victims, intimate partner violence, over 40% of women are nearly 15% of men reported injury. Often the head, neck, or face victim are also at the elevated risk of experiencing asthma, 23%. Fine. Gastrointestinal disorders such as the irritable bowel syndrome, 12.4%, frequent headache, 28.7%, chronic pain, 29.8%, sexual transmitted infection, 4.3%, and activity limited, 35%, and mental health outcome, including depression, anxiety, post-traumatic stress disorder, suicidality, and chronic mental illness, child exposure to intimate partner violence in the family, experiences psychological, social, physical, and cognitive consequences such as the emotional dysregulation and internalizing or externalizing behavior. Will establish a consequence of elder abuse or higher level of stress and depression, developing fear and anxiety reactions, suicidal ideation, attempt social isolation. Unfortunately, sexual behavior being the common form with the lifetime prevalence estimated at the 44% for women and 25% for men. According to the National Crime Victimization Survey, rate for elevation higher in the women than the men. Numerous mental health consequences include the depression 13 to 51%, anxiety 12 to 40%, substance abuse 13 to 61%, sleep disorder 19%, and post-traumatic stress disorder 17 to 65%. Approximately half of the people with bipolar disorder experience sexual assault, suicidal attempt, and complete suicidal fourfold higher, twofold higher for eating disorder, threefold greater risk for substance suicide attempt compared to women without a history of sexual assault. Sexual assault is associated with the shortened of telomere length, which is the high sign of cellular stress and aging. Bullying is a common among the youth and has a long-term consequence for the target perpetrator and bystander. Somatization symptoms, the expression of the mental phenomena or a physical or somatic manifestation, such as the headache, chronic abdominal or other pain, and sleep disturbances, is twofold increase among youth who is a bullied. One step ahead for prevention. Preventing violence and trauma is a prerequisite for health equity. Violence and fear of violence is a health disparity, and violence can also worsen other health disparities. Wide strategy to prevent violence affecting young people include street outreach and interruption in neighborhood health, highly impacted by violence, universally school-based violence prevention at all schools, treating mental health problem and substance abuse and enhancing protective factor among the youth and prevent mental illness and substance abuse, reducing young children exposure to violence in homes and community. Other effective strategies then may be prioritized at the local level of sustained reduction in violence or foster social connection in neighborhood, enhance economic development, including youth employment, establish a conflict resolution program, foster youth leadership, ensure quality of after school and out of school programming, establish monitoring initiatives, enhance quality early care and education, promote positive social and emotional development, teach parenting skills, ensure family support service, and support successful re-entry. Policies helped create the inequitable conditions that perpetuate violence such as a health disparity. The principal can guide effort of the dismantle and preserve inequitable neighborhood condition. Because of the cumulative impact of the multiple stressors, overall the approach should be shifted toward the changing community conditions, away from blaming individuals, a group, for their disadvantaged status, understanding and owning for the historical forces, acknowledging the cumulative impact of the stressful experience and multiple risk factors in the environment is crucial, especially since this source of chronic stress and risk factor tend to occur in area of concentrated poverty. For some families, poverty lasts to a
Dr. Bhadaru, thank you for joining us online. Your video has exceeded time, so we are cutting it short. We'll now move on to the questions from the judges and moderators and from the audience.
Yeah, you have spoken about a national crime victimization survey which showed so much prevalence of various problems. Can you tell us a bit about where it was done or when?
Between 2021, ma'am, 2021.
Where was it done? Where was it done? Because we have an NCRB, which we take all the crime records. But this one I have not heard of, so I'm just wondering where it was done and when. When you said 2021, but where was it conducted?
Hello? From 2020, 21, ma'am.
Where? Is it all over the country? Is it in Indian data and or in some states?
In Indian data, ma'am.
Okay. Who conducted it?
Hello?
Yeah. Who conducted this survey?
Government of India, ma'am.
Okay.
If there are no further questions, we'll move on to our next presenter, Dr. Sharon Cynthia. She is presenting on Missing the Trees for the Forest, a survey of sub-district level mortality pattern in North Bihar, India.
Good afternoon, everyone. Missing the Trees for the Forest, a survey of sub-district level mortality pattern in North Bihar, India. Mortality indicators are powerful tools to assess the level of equity in a region. Proportional mortality rates calculated within the states of India have revealed that several nations exist within this single nation because of the wide differences between the epidemiological transition level of each state. But when we take a particular state, the differences in the regions within the state could go unnoticed between the confidence limits. This study aimed to look if health disparities exist between a particular pocket of the state of Bihar, namely North Bihar, and the rest of the state. So a cross-sectional survey of 6 blocks in East Champaran district was done using multi-stage cluster sampling. 34,814 persons were surveyed. Among them, 229 deaths were identified. The sequence of events that occurred around the time of these deaths were recorded by trained community volunteers in a tool called verbal autopsy. This report was further assessed and coded by a physician using ICD-10 coding to identify the cause of death. The proportional mortality rates and cause-specific mortality rates were calculated for these 229 deaths. The findings of the paper showed that the region's proportional mortality was quite different from that of the state of Bihar, shown in the outer ring here. The maternal and neonatal disorders predominated the cause of death in East Champaran, whereas cardiovascular diseases and neoplasms were the top causes of death in the state of Bihar. Among the 229 deaths that were identified, 101 were of children aged 5 years and below. Among these, nearly half had died within the first month of life. Nearly 1/3 had died at home without any health care, and the reasons for death were identified as infections and birth asphyxia in nearly 3/4 of the babies. The infant mortality rate and the under 5 mortality rate were nearly double that of the state and the country average. Followed by maternal and neonatal disorders was respiratory diseases. The specific cause-specific mortality rate of respiratory diseases was quite high as compared to the state levels. The use of solid fuels and indoor air pollution has been closely associated with the high prevalence and death due to respiratory diseases. The third highest cause of death was infections, among which tuberculosis was predominant. The cause-specific mortality rate of TB was 54 per 100,000 population as compared to 32 in the country. Several diseases which are in the stage of elimination in the rest of the country still caused death in this particular cluster. These were measles, tetanus, kala azar, and cholera, to name a few. In the 15 to 49-year age group, deaths due to accidents and unintentional injuries among migrants workers have been documented as a predominant cause. The study concludes that disaggregated regional mortality rates thus bring to light several disparities and inequities in terms of access to basic and emergency primary health care. So the study recommends that the mortality rate assessments be done on a community-based level using tools like verbal autopsies, using community volunteers, rather than hospital-based mortality data. This would enable better planning and implementation of healthcare programs. Thank you.
Thank you for this. Can you just define for us epidemiological transition index?
Ma'am, it is communicable maternal, neonatal, and nutritional disorders. The deaths due to these divided by the non-communicable diseases and injuries. So a level less than 1 is supposed to be of the more developed regions because we have overcome those communicable maternal neonatal diseases. But in this area, it was 1.12, which shows that numerator is still large.
It's an interesting study. Good one. Actually, you compared data from 6 blocks in East Chambaran, the field data from the community.
Yes.
And compared it with the data available on records, which is supposed to be hospital-based data. Is it different because something specific to Chambaran, or is it because the is it hospital data versus community data, or is it local data versus state data?
Yeah. These 6 blocks were the catchment area of the hospital where the study was done. So this was to highlight that this was a much neglected area as compared to the rest of the state. So that was the point of the study.
I think the other data was from the registered deaths, right?
Global burden of disease data.
No.
They had million deaths.
You were comparing it with the Registrar General of India's registered births and deaths.
Yes.
That was the source of data.
Yes.
We'll move on to our next presenter, Dr. Patlolla Sriram Yadav. He's presenting on navigating the terrain of health disparities, a closer look at disability among diabetic elderly.
Everyone, my name is Sriram Yadav. I'm currently pursuing my PhD in Public Health from School of Medical Sciences, University of Hyderabad. I'm delighted to present my poster on the topic of navigating the terrain of health disparities, a closer look at disability among diabetic elderly. This poster is part of the Medicine Annual Conference, Equity in Health Clinical Approaches to Addressing Health Disparities, Strengthening Diabetes is a chronic condition that affects millions of people around the world. It can cause serious complications such as heart disease, kidney failure, and blindness. Diabetes can also increase the risk of disability, especially among older adults. Disability can affect a person's mobility, vision, hearing, cognition, and mental health. Now imagine being old, diabetic, disabled. How would you access healthcare services? How would you manage your condition? How would you cope up with challenges of daily life? These are some of the questions that I wanted to explore in my research. I wanted to understand the barriers that prevent this group of people from getting the care and support they need. I also wanted to suggest some ways to overcome these barriers and reduce health disparities. To do this, I looked at different factors that affect healthcare access and quality of diabetic elderly people with disabilities. These factors include socioeconomic constraints such as poverty, illiteracy, and lack of insurance, geographical disparities such as distance, transportation, and availability of services, awareness gaps such as lack of knowledge, information, and education about diabetes and disability, shortage in healthcare infrastructure such as shortage of staff, equipment, and facilities, social stigma such as discrimination, prejudice, and isolation. I found that these factors create a complex and challenging situation for diabetic elderly people with disabilities. They face many obstacles and difficulties in getting the care and support they need. They often experience poor health outcomes and low quality of life. So, what can we do to help them? How can we make healthcare more inclusive and equitable for them? In my research, I proposed some possible strategies and interventions such as policy changes, such as improving social security, ensuring coverage, and legal rights for diabetic elderly people with disabilities. Community-based interventions such as raising awareness, providing education, and creating support groups for diabetic elderly people with disabilities. Telemedicine and home-based care such as using technology, mobile devices, and online platforms to deliver healthcare services to diabetic elderly people with disabilities. These are some of the ways that can address the health disparities among diabetic elderly people with disabilities. By doing so, we can improve their health and well-being and make healthcare more inclusive and equitable for everyone. Thank you for listening my presentation. I hope you find it interesting and informative. If you have any questions or comments, please feel free to ask me. You can also contact me by email Patlolla Sriram Yadav@gmail.com. I would also like to thank my supervisor and co-authors for their guidance and support in this research. Lastly, I would like to thank the organizers of the conference for giving me this opportunity to share my work with you. Thank you and have a great day.
Hello. Yeah. Can you hear me?
Yes, sir.
What exactly was the methodology? Because you mentioned that it's a rigorous methodology in looking at barriers, and we could not see any data or anything related to methodology in the poster. How did you arrive at this conclusion? What was the source?
So actually, sir, this is my part of my PhD topic. My title, Profiling of Disability Among Diabetic Elderly. So I did cross-sectional study for extracting the data. So this is a overall review and practical experiences of the in the field. So I compile all these things in one review paper.
Yeah, but if you had actually given us the thing, no, that you had interviewed so many patients and these were the disabilities they had and these were the problems they had in accessing care, that
Yes,
would
sir.
have made it better for us to understand.
Yes, ma'am.
What
But till now, I completed a pilot study, ma'am. My overall sample size is around 550. Among that, 54 I completed the data collection as part of my pilot study. So that's why I didn't include the exact statistic numbers in this paper.
There are no further questions from the audience. We'll move on to our last presenter, Dr. Yaipharembi Huyam. They are presenting on inpatient satisfaction survey of a tertiary hospital in Imphal West, Manipur, based on the National Quality Assurance Guidelines.
A very good afternoon to you all. I am Dr. Yaipharembi Huyam from Department of Community Medicine, RIMS, Imphal. Today I will be presenting on a study titled Inpatient Satisfaction Survey of Tertiary Hospital in Imphal West, Manipur, based on National Quality Assurance Guideline, a cross-sectional study. Coming to introduction, patient satisfaction is an essential component of quality improvement of hospital service. Patient care without quality has been reported to compromise patient safety. The objective of the study was to assess patient satisfaction score among inpatients of tertiary hospital in Imphal West, Manipur. Method: a cross-sectional study was conducted from 6 March to 31st March in Regional Institute of Medical Sciences. Sample size calculated was 422. Study instrument structure: questionnaire based on Inpatient feedback format of National Quality Assurance Standard were used. Operational definition: a score of less than 75% is defined as poor satisfaction. Poor patient satisfaction score and a score of greater than equal to 75% is defined as good patient satisfaction score. Data collection: face-to-face interview were conducted in English or Manipuri language. Informed written or verbal consent was taken from the participant. Ethical issues: approval obtained from research ethics board RIMS, and data analysis. Descriptive static like median, interquartile range, percentage and frequency extra were used to summarize the data. The score of patient satisfaction survey were given in 5-point Likert scale and converted to corresponding percentage from the 5-point Likert scale. Coming to result, total respondent were 424 with median age of participant were 38 years, minimum is 18 and maximum is 90 years. Coming to figure 1, distribution of participant by total number of days in hospital. Here, 37.3% of the participant stay for 1 to 3 days in a hospital. Table number 1 shows participant feedback based on NQAS inpatient feedback form. Here, highest attribute was your overall satisfaction during the treatment as an inpatient with 96%, and the lowest attribute was all prescribed drugs were made available from hospital supply with 37%. 6 attribute have a score of less than 75%, and good patient satisfaction score 12 attribute have a score of greater than equal to 75%. Overall satisfaction score were 80%. Coming to strength, the first of its kind using NQAS guideline, and the study finding could be used as baseline for further study. Limitation: the NQAS PPS guideline has not been used in Toto as the question on the charts was sent into admission. Coming to conclusion, majority of patients were satisfied with overall care received. Patient was found to be unsatisfied in the attribute pertaining to waiting time at registration or admission counter, cleanliness of bathroom, to toilet, bed sheet, pillow, cover extra, and availability of prescribed drug from hospital supply, availability of diagnostic timeline, timeliness of supply of diet, and its quality. And these are my reference, and here ends my presentation. Thank you, everyone. Thank you.
Thank you, ma'am. Which year was this study done? I couldn't read it.
Hello?
Yeah, can you hear me?
Yes, ma'am.
Which year was this study done?
Ma'am, it was conducted this year only.
This year?
Yes, ma'am.
Okay. Has there been a follow-up in terms of saying that the linen should be cleaner and, the complaints that the patients, they were not satisfied? So has this been...
Ma'am, since it was a cross-sectional study, we didn't do follow-up.
No, I don't mean that. I mean that was it presented to the hospital administration to take decisions about how to improve services?
Okay, ma'am, the report has been submitted to the hospital authority for further exercising whatever is lacking behind. So the functioning part or the exercising part is from them. So like the data we got just after the study and the current, we haven't went again and checked.
Yeah, I think you should follow up as a department because 2 big things. One was the linen cleanliness. Second thing was availability of drugs in the pharmacy. So whether it's a question of budget or whatever it is, because that would really help, improve quality of care.
Yes, ma'am. Yes, ma'am. Yes,
this brings us to the end of the e-poster presentation of the track 1. I would like to thank our judges and moderators for being present here and for adding your insights. Thank you, Dr. Suresh Kumar, and thank you, Dr. Ramani, for being present with us.